All right. Can you guys see my PowerPoint?
Yes.
Awesome. All right. So today we're going to talk about anesthesia and pain control. We're going to discuss different kinds and also set up for topical. Now, anxiety and pain control practice of various psychological, physical, and chemical approaches to prevent and treat preoperative, operative, and postoperative anxiety and pain. Anesthesia is the term used for temporary loss of feeling or sensation. Anesthetics are the drugs that produce the temporary loss of feeling or sensation, and there's different methods of pain control that we use in the office. Topical anesthesia, local inhalation sedation, anti-anxiety agents, intravenous sedation, and general. And topical is mainly what you guys are going to be putting on the patient. It provides a temporary numbing effect on nerve endings located on the surface of the oral mucosa. It's supplied as ointments, liquids, sprays, or patches. I will tell you though that the most common one we use in the office is gel. It comes, this is a little different kind, but it comes like in a little jar, and we take a cotton tip applicator and we put a little bit on the cotton tip applicator, and then we put it in the area above the tooth on the tissue where it's going to be injected. We'll talk a little bit more about that. And also, if you look in your chapter in the back, you need to start reading the procedures, because the procedures are the ones that you will be doing. And topical is a big one. Topical, you probably will do every single day of your dental assisting career. Now, local anesthesia, it was discovered somewhere in the mid 1800s and has greatly reduced pain during dental care. It is the most frequently used for pain control in dentistry, local anesthesia, that is, because it provides a safe, effective, and dependable method of anesthesia of suitable duration for virtually all forms of dental treatment. The characteristics of local is non-irritating to the tissues in the area of the injection. It's associated with minimal toxicity, rapid onset, able to provide profound anesthesia, sufficient duration of action, completely reversible, sterile or capable of being sterilized by heat without deterioration. Now, the method of action, local anesthesia temporarily blocks the normal generation and conduction action of the nerve impulses. It's obtained by injecting the anesthetic agent near the nerve in the area intended for dental treatment. The induction time is the length of time from the injection of the anesthetic solution to complete and effective conduction blockage. So usually while the patient is getting numb, so you put the topical, you set up the syringe, doc comes in, gives them the anesthetic, and then he leaves. This is the time for you to make sure that you have everything you need for the procedure. Double check, because once the doctor comes back, he's ready to sit and start working. He doesn't want to hear that you forgot something, okay? So you want to make sure everything is ready. Now, the time span of anesthetics, again, time from induction to completion of the reversal process. The short acting is about 30 minutes, intermediate 60, and the long is 90 minutes. Now, everybody's different. So some people will say they've been numb for hours. Some people will say they're not numb at all. So everybody is different. Vasoconstrictors and anesthetics. Indication for use: prolong the duration of an anesthetic agent by decreasing the blood flow in the immediate area of the injection, decrease bleeding in the area during surgical procedures. So the main one is epinephrine. You're going to see that a lot in the office. So in surgery cases, as I mentioned here, they use it a lot because it helps decrease the bleeding, so that way the doctor can work in a field that he can see, you know, because he needs the field to be clear. Now, will there be bleeding? Of course, but it just helps decrease it. Now, the anesthetic solution to vasoconstrictor, the ratio is different. So it all depends on which one you pick, okay? And these are some examples here. Um, basically, uh, if you look down on the bottom here, it says what ratio represents a higher concentration of vasoconstrictor mixed with local anesthetic? Okay, it's the first one, all right? And what that means is that there's 1 gram or 100 milligrams of solute drug contained in 20,000 milliliters of solution. Um, we use a higher concentration of vasoconstrictor to prolong the effect of the local anesthesia and again to decrease control bleeding in the area. So super important. Now, how many carpules do you get out? Get out a few, okay? Because you never know how many the doctor has to give. Just don't get out one, okay? Because one is usually never. I usually get out anywhere from 2 to 3 carpules. And if it's a lot of extractions, I get out a couple of more. Now, contraindications to vasoconstrictors: unstable angina, recent myocardial infarction, recent coronary artery bypass surgery, untreated or uncontrolled severe hypertension, or untreated or uncontrolled congestive heart failure. So basically, what this is trying to say is that people with heart problems, we usually don't give them epinephrine. We give them some other type of solution, okay? This is why it's important to read the medical history and make sure that we're giving the people that have medical problems the right anesthetic. Because if not, we can have problems in our dental chair. And unfortunately, if we have any problems, we will have to call 911, and we don't want to do that. So please make sure you read the medical history. Now, injection techniques. Now, there's different injection techniques. Do you give injections? No, the doctor does. But why do you need to know this? Well, you need to know this so that way you know where you're going to put the topical, okay? So the location and innervation of the tooth or teeth to be anesthetized will determine where topical anesthetic is placed and the type of injection given. So you have the maxillary, the palatal, the mandibular, and then you also have the periodontal ligament injection. Starting with the maxillary, local infiltration is completed by injecting into a small isolated area. Field block refers to the injection of anesthetic near a larger terminal nerve branch, and nerve block occurs when local anesthetic is deposited close to a main nerve trunk. So take this picture for instance, okay? If you look at the first one, where the arrow is circled, that's where the doctor will give the local, okay? So you will put the topical in that area. For letter B is field block. So it's just a little bit off to the side. And for letter C is a nerve block, so a little bit higher. To be quite honest, you know, your main thing is find out what tooth he's going to be working on, okay? And when you put the topical, spread it along that area just in case he decides to give a local, a field, or a nerve, because you're not sure, okay? You know what area he's going to be in. So just make sure you put, again, in that area, and then you go from there. Once you get used to your doctor, you will know what type of injections the doctor consistently gives in certain areas, and then you could be more specific on the topical. Now, palatal, that's the local that we put on the palate area. It may be necessary for procedures that involve the soft tissues of the palate, the anterior greater palatine nerve block or the nasal palatine nerve block, and that looks like this. Now, I will tell you that these injections for the patients hurt, okay, on the roof of the mouth. So make sure you put a nice topical there in the area that he's going to be working in so they don't feel that injection so much, because again, those injections are probably the injections that hurt the most, okay? And then you have mandibular anesthesia. So on the mandibular, he gives what's called either a block, which is frequently required for most mandibular teeth. The solution is injected near a major nerve, and the entire area served by that nerve branch is numb. You have the inferior alveolar nerve block, which is the mandibular nerve block, the buccal nerve block, and the incisive nerve block. And it looks like this. So the top one is inferior. So that looks like it's all the way in the back. Actually, they all look like, you know, they're pretty close. So again, when you're giving topical, now this is a different situation. You give it in the where the tooth is and a little bit higher on the cheek area. Okay, because look at B. B is a buccal nerve block. So again, it looks like on the cheek. So you would have to numb that section up. And then C is incisive. So this one is below. So again, you're not sure, that I would put topical all on the bottom here and a little bit on the cheek. So when the doctor gives anesthetic, they don't feel it. Then there's that periodontal ligament injection. The injection of the anesthetic solution under pressure directly into the periodontal ligament and surrounding tissues. Periodontal ligament injection is generally an adjunct, that means an addition to conventional techniques. And it looks something like this, okay? So letter A and letter B. All right, so again, does the doctor always give this type of injection? No, not really. All doctors are different. Again, you'll know what your doctor likes, and then you'll go from there. Now, local anesthesia setup, of course, you need your anesthetic syringe. Some people call it also the aspirating syringe. So anesthetic or aspirating. What we don't call it is the needle, okay? Or we're going to give you an injection. We try to refrain from negative connotations. Patients are scared already. Please don't scare them even more, okay? So use the word, we're going to give you anesthetic. And if they say, what is that? Say, oh, we're going to numb up the area. Don't say, well, it's a needle on a syringe and it's pretty big and blah, blah, blah. They don't want to hear that, okay? And then we have the cartridges. They come in color coding. I'll show you that in a second, and how to handle them, and of course the disposable needle. Now, the first thing that you guys need to know is the syringe, okay? The parts of it. So starting from letter A, that's the needle adapter. B is the barrel. C, this is the harpoon right over here, okay? So C, you will find it if you look on the top one that's already put together. It's hard to see it, but it would be where my arrow is, okay? At the end of the ring, so right here. D is the piston. E is guide ring. F is the spring, so that's what pulls the syringe cartridge back and forward. G is where the doctor puts their finger, and H is where he puts his thumb. Okay, so again, when you come into the office, you need to know these parts because you're the one who puts the syringe together. And here is the cartridge, okay? So local anesthetic solutions are supplied in glass cartridges. So we have to be real careful that we do not drop it. So here's the parts of a cartridges. You have the aluminum cap, the glass cartridge, and they come in different colors. Again, I'll go over that in a second. You have the rubber diaphragm and the silicone rubber stopper, okay? Now, just so you know, this stopper goes in the harpoon. So C is the harpoon. So the stopper always comes down here, okay, in this part right here where my arrow is. The diaphragm, the rubber diaphragm, see how there's just a little hole? That's meant to be up here. So when we put the needle in, it goes right into the diaphragm, okay? And of course, the cartridge goes in the barrel, okay? Coming to here. So I mentioned color codes, okay? So if you notice, there's all these colors here. Well, the colors represent what type of local anesthetic cartridge they are. Again, I mentioned lidocaine is the most used, okay? So as you can see here, there's one in red and one in green. Why? Because if you look over here, the ratios are a little bit different, even though it says lidocaine 2% with epinephrine. So again, you'll see what the doctor prefers. He's not going to have all these colors. He's going to have his favorite. It might be lidocaine, for people that can have anesthetic that don't have any heart problems. If they do have problems, he might have mepivacaine or carbocaine. I know carbocaine is not listed on here, but I say those because those are the most common in the office. So again, you'll get to learn. When you're in the office, you really need to pay attention and see, okay, this person has no medical problems. The doctor's using lidocaine. Oh, this person has medical problems. He's using mepivacaine. So it's really important again to identify those colors. And also, if you're having problems with your eyes, please have them checked before you go out on extern, because this stuff here is very tiny to read. And if you on the carpio, it will say the words, but if you don't remember what the color coded band is, then you need to know what the words say. So you don't want to pick up the wrong one. Now, the guidelines for handling anesthetic cartridges, they should be stored at room temperature and protected from direct sunlight. So usually they're stored in the drawer. Never use a cartridge that has been frozen, cracked, chipped, or damaged in any way. Never use a solution that's discolored or past the expiration date. Do not leave the syringe preloaded with the needle attached for an extended period, and never save a cartridge for reuse. So once you use a cartridge on a patient, even if there's a whole bunch of solution in there, it still goes in the sharps, okay? And if you don't know the sharps is the red container. Now, this is what the disposable needles, they come in many different sizes. Usually by the caps, you may know also colors, what size they are. If you look over here, once you take off the cap, this is what the needle looks like. Okay. Notice how they go from big, some of them are small, some of them are medium. Normally they're called long and short. Okay, so again, you will realize once you're working with the doctor where he's working at and where he likes to use short needles and where he likes to use long needles. Most doctors use the long ones on the bottom and the short ones on the top. But again, depending in the area, everybody's a little bit different, okay? If you look over here, number one, that's the end of the needle. Two, this is the needle hub. Three, this is the injection end of the needle. So, of course, the needle's really not that big, but once you put it on the syringe, it looks like this big old thing is coming to the patient, and that's why they get scared. Number four is the protective cap. Number five, there's always a seal on every needle. And then number six is the needle guard, okay? Now, complications and precautions. Injection into a blood vessel infected area, toxic reactions, it could be localized or systemic, temporary numbness, and paresthesia. So what you guys have to do is you always get consent before a procedure, and you have them sign the consent, because the consent will also say, if the doctor gives you anesthetic and you're infected or you get temporary numbness or paresthesia, these are the complications that may arise. So these are the things that we have to let the patients know, and that's why they have to sign a consent for every procedure that we do. Before I move on, does anybody have any questions? No? Okay. I do want to say one other thing, and I've been saying this in the lab too when we do have students come in. Number one thing that you guys must remember is we never recap. Recap means that we do it with our hands. We put the cap back on the needle with our fingers. We do not do that. I will show you how to recap whether we have a safety to use, or if you don't have a safety, how the end of this cap of the needle is flat and you just stand it up and put the needle right in without using your other hand. Because again, if you slip and the needle goes in your finger, that's a whole different situation, and you don't want to get into that, okay? You would have to fill out paperwork, go to the doctor, let your doctor know exactly what happens. They're going to have to send you out. You're going to need all kinds of stuff. So it's a problem. So make sure that you don't recap, and that's how we avoid getting sticks or pricks in your fingers or hands. Moving on to inhalation sedation. Now, if your office offers this, not everybody offers this. If they do, though, they will train you because every office is a little bit different in how they have the setup. But there are two things, the nitrous oxide and the oxygen, the combination of gases inhaled to help eliminate fear and to aid relaxation. This dates back to 1844. Dr. Horace Wells was the first to use on patients. The effects of this is non-addictive and the onset is easy, side effects are minimal, and recovery is rapid. It produces stage 1 anesthesia and it dulls the perception of pain. Now, I'm pretty sure you've seen these things like on TV. They show it a lot, like laughing gas. We have to be really careful about using this, and we'll talk a little bit more about it. But the advantages is administration is simple and easily managed. The services of an anesthesiologist or other special personnel are not required. Excellent safety records, side effects are minimal, the patient is awake, recovery is rapid, and it can be used with patients of all ages. But the disadvantages, some patients may experience nausea or vertigo, and patients who have behavioral problems may react in a negative way and act out those behavioral issues. Some people don't remember and they act funny. That's why you see all these videos posted on YouTube or wherever of funny things that people do after they've been on nitrous. Now, the contraindications, the people that cannot use it is pregnancy in the first trimester, anybody that's got any nasal obstruction. So those are problems inhaling through the nose. Anybody that has emphysema, multiple sclerosis, or emotional instability. So we would not use it on any of those people. The effects, the toxic substance is used properly. Safest maximum allowable amount in the dental environment is 50 parts per million. It's never administered unnecessarily or used for recreational purposes, and it could lead to abuse, okay? So it's only used during patient treatment. Now there's cylinders. So the gases are dispensed from steel cylinders, which are colored green for oxygen and blue for nitrous. So if you do have it in your office, you have to know what the tanks are. Now the nitrous are portable or part of the dental unit. The control valves control the flow of each gas. There's a flow meter indicates the rate of flow of the gases, and the two gases are combined in a reservoir bag, which the patient draws on for breathing. So again, that's why if they have it in the office, they'll show you the gauges and everything that you would need to know. Now, there's also a gas hose that carries the gases from the reservoir bag to the mask or nose piece. And there's mask that's supplied in sizes for adult and children, and the nose piece through which the patient breathes the gases. And this is what the portable one looks like. Okay, so there's that bag that both the oxygen and the nitrous goes in. Here is in the office if you have to hook up the hoses. And the reason why you need to do this, and they're in color, again, blue, nitrous, green, oxygen, and then the white in the middle. You need to know this because if you can't put it in the wrong place. Now, the good things is that usually everything is labeled. Okay, so just follow the label, the marking of the label. Okay. Now, during the time that we're giving the nitrous, patient assessment and monitoring must be done. So if you are in an office that's doing it, watch what they do first, take notes, so then that way when they put you to do it, you know what's going on. So always review the patient's medical history. I mean, that's a must in any procedure. Okay, the sedative effects of nitrous and oxygen may enhance the effects of medications directly or indirectly. You usually obtain vital signs of blood pressure, pulse, and respiration before, during, and after administration. And pre-operative, you always get a baseline, and post-operative, you want to confirm the patient's recovery or to identify any adverse responses. You give the patient education for inhalation sedation. You describe the procedure of administering the gases. You describe the use of the mask and the importance of nasal breathing. You describe the sensations that the patient will experience, and you will reassure the patient. Administration, you will start with pure oxygen. While establishing the patient's tidal volume, you slowly titrate the nitrous oxide until the desired results are achieved. The patient should refrain from talking or mouth breathing, and the nitrous oxygen analgesia should end with the administration of 100% oxygen for 3 to 5 minutes. So in other words, once you finish, you give pure oxygen for 3 to 5 minutes to bring the patient back. Obtain post-operative vital signs and compare them with the pre-operative recording. Now, the safety work practices for the clinical team, which is you only use it for patient treatment. Don't be playing around in the office with it. Never administer for recreational. Reducing nitrous oxygen hazards to dental personnel. They use something called a scavenger system. You make sure the patient mask fits well. You discourage the patient from talking. You vent gas outside the building. You routinely inspect equipment and hoses for leaks. And a lot of times they use a monitoring badge system to detect any nitrous. The scavenger system, it's essential for protection from the occupational risk of nitrous. Members of the dental team use a scavenger system to reduce the amount of it that escapes into the atmosphere of the dental suite or office, which is then inhaled. The scavenger system is recommended to reduce the nitrous release into the treatment room, and it looks like this. Okay, so, if we're giving it, we don't want to smell it because then we're not going to be able to do our job. So we got to make sure that it's going in the scavenger system. Now, the anti-anxiety agents. So sometimes other than nitrous, we might give sedatives, and that's the drug of choice for physician and dentists seeking to relieve anxiety in their patients. So a lot of patients are anxious about coming to the office. So anybody that comes in, the criteria, they have to be nervous about a procedure. If the procedure is long or difficult, if they're mentally challenged, or if a patient's very young requiring extensive treatment, that's who we would give the sedatives to. Commonly prescribed sedatives, okay, these are some. I will tell you that the most common in the office is diazepam, which is your volume, okay? When we give sedatives, we ask them to come with somebody so they can drive them and bring them home, because we don't want them driving with them having the sedative in their system. Intravenous sedation. So another one, anti-anxiety drugs administered, okay, IV throughout a procedure at a slower pace, providing a deeper stage 1, okay. Analgesia. Patient, again, pretty much everything's the same like all the other stuff. We make sure medical history, we check their physical examination, doc does that. And again, sign consent for everything that we do. Baseline, we always have to take a baseline, what their vital signs were before and then after. Oximetry and electrocardiography are performed and recorded. The patient's weight is taken and recorded for the determination of dosage. So again, normally, I'll be honest with you, the people that really do IV sedations are usually the oral surgeons, okay? Because especially if they have wisdom teeth to pull out, or major multiple teeth to extract, they will be the ones to do it. Not so much general, okay? But we'll still talk about it. So IV sedation, patient monitoring, psychological measurements are recorded every 15 minutes. We're looking for a level of consciousness, respiratory function, oximetry, blood pressure, heart rate, and cardiac rhythm. We got to make sure the heart is still going. Now, general, that's another one that's usually done in the hospital. So if your doctor is a traveling doctor and he goes to the hospital, then you will go to the hospital with him to assist him. But in the hospital, they will have an anesthesiologist there. So a controlled state of unconsciousness with a loss of protective reflexes, including the ability to maintain an airway independently and to respond appropriately to physical stimulation or verbal command, that produces stage 3 general anesthesia. Now, pharmacological makeup, that's a combination of gases. That's your nitrous and oxygen, okay? It could be halothane or enflurane mixture, IV agents such as thiopentyl sodium or methylhexadyl sodium. So it could be any of that. 4 stages of anesthesia. So again, stage 1. At this stage, the patient is relaxed and fully conscious. The patient is able to keep his or her mouth open without assistance and is capable of following directions. The patient has a sense of euphoria and a reduction in pain. Vital signs are normal. The patient can move into different levels of analgesia. Stage 2, they start getting that excitement stage. At this stage, the patient is less aware of his or her immediate surroundings. They start to become unconscious. They may become excited and unmanageable. Nausea and vomiting may occur, and this is the undesirable stage. So stage 2 is the stage that you want it to go quickly. Stage 3, this is the general anesthesia stage where they begin to calm down after stage 2. They feel no pain or sensation. They become unconscious. This stage of anesthesia can be met only under the guidance of an anesthesiologist in a controlled environment such as a hospital, as I mentioned before. 4 stages of anesthesia, the stage 4, respiratory failure or cardiac arrest. So at this stage, the lungs and heart slow down or stop functioning. If this stage is not reversed quickly, the patient will die. So now you know why it's done in a hospital setting, okay? Patient preparation, again, physical examination, laboratory tests, and again, signature for their consent form. And patient education, the dentist will review the procedure as well as the risk, and the patients must not have anything to drink or eat 8 to 12 hours before undergoing general anesthesia. Their recovery, once the procedure is completed, the patient is monitored closely until normal reflexes return, and then the patient should not be left alone while regaining consciousness. So we have to make sure everything is okay. Don't walk away from them because that's when things become a little bit complicated. Mind-body medicine. So there's methods of reducing anxiety and pain through different non-pharmacological techniques. Some common techniques include distraction, like listening to music, watching their iPad. Some doctors have TV, put on videos, relaxation techniques, guided techniques, deep breathing, biofeedback, hypnosis, acupuncture. Uh, you know, in a dental office, we don't really do that except mainly telling them deep breathing and stuff. You don't see us giving them acupuncture or hypnosis. Now they can go somewhere and get it and then come to their appointment, but we don't really do that in the office. Now, documentation of anesthesia and pain control. So for any type, whether we talked about local, IV, nitrous, general, whatever, you always have to document the following measures and observations. Review of the patient's medical history, preoperative and postoperative vital signs, patient's tidal volume if inhalation sedation is being used, times at which anesthesia began and ended, peak concentration administered, postoperative time in minutes required for patient recovery, and adverse events and patient complaints. Now, I will say this, being that dentistry is mostly local, especially for general, okay, what you want to count and what you want to write in the chart is how many cartridges the doctor used and what kind. So in the chart, if it's Lido with 2% epinephrine, you would write that in the chart. And if the doctor gave 3, you would write times 3. Okay, that would indicate how many the doctor gave. It's important because God forbid something happens to the patient, you have the chart to refer back to how many cartridges were given. There's a specific amount of how many the doctor can give, and he's the best one to know. Okay, but again, that's why I only take about 2 to 3. If it's a bigger procedure, I take out more. But no matter what procedure you're using, you have to document precisely, accurately, without mistakes, because once you write up a chart, that can go to a court of law if the patient ever decides to sue. So you have to be real careful. Any questions? No questions?